Right, so we're talking about lipids, and in particular, I said we'd have a look at some common lipid patterns, but what I wanted to mainly do is to put that lipids in the context of what sort of questions you're asking, but I'll just do a very super brief recap of lipids. So the main lipids you're going to be interested in, as you said, LDL and HDL. So LDL is low density lipoproteins and HDL is high density lipoproteins. And basically they perform opposite roles. So the LDL is what is moving cholesterol to the peripheral part of the body. And in particular, we usually are interested in how much ends up stuck in our arteries as a cause of cardiovascular risk. And then the HDL cholesterol is the main mechanism for carrying cholesterol away from the periphery back to the liver where it can be reprocessed. And for that reason, they've often got the name of bad cholesterol for LDL and good cholesterol for HDL. If you read in the articles, you'll see there's lots of nuances to this, and say in diabetes, the LDL sometimes is particularly gnarly little small bits of LDL which are atherogenic more than just the general LDL, and sometimes with the HDL cholesterol you might read alcoholics have more HDL, but it's not all of the best type, so there's some nuances beyond that. But just thinking of LDL as the bad cholesterol and HDL as the good cholesterol stands you in good stead. Now this isn't something to remember, but this is really what we do with lipids in the body. So you can see it's quite complicated, and in fact, although we're interested largely in cholesterol from a cardiovascular risk point of view, the main interest as far as the body goes is using lipids for things like cell membranes, using it for synthesizing other molecules that it needs. So there's a lot of functions of lipids, and a lot of lipids end up as messengers or being converted into messenger type material. So although we're thinking of LDL and HDL and triglycerides, really the body, that's just sort of a bit of a side effect. The body's really interested in lipids for other reasons, but from a health point of view, we're interested in it from how those lipids in the circulation largely impact our body as a whole. So when the question is, when you ask you to interpret some lipids, the question of what do these lipids mean? And it's really important to understand the question, I think, before you try and give an answer. An example of someone who didn't understand the question. Find X, here it is. No marks for that, because you misunderstood the question. And so the question of what do these lipids mean, I think doesn't really have a good answer unless you know the context in which the question's being asked, and that's going to vary from patient to patient and also vary a bit from your clinical setting to clinical setting. If you're in a diabetic clinic, it's going to be different than if you're in a pure general practice sort of situation, or if you're in a pediatric practice, it's going to be different again. So what I mean by context, well, you can look at it in lots of ways, but the way I tend to look at it is three aspects. One is the patient itself and themselves, and obviously these days we're really focused on patient-focused care, and so it's always important to remember that the thing you're looking at isn't some figures on a bit of paper. It's just something that's reflecting the concerns of what's going on in terms of a real person. Each of those people will have a particular problem, and you're not always addressing the same problem in the same patient every day. So sometimes the patient's there for a particular reason, and you're really asking a question about that particular problem, not just a whole of patient sort of question. And in that way, I think of that in terms of what part of the medical process is in play at the time, and I'll go into that in a bit later on. But even one person with one problem, they're often going through different phases of management or diagnosis or some type of care through their whole process. And again, you might be asking different questions depending on where you are in the course of care of a patient. Sometime you might be asking, for example, with cholesterol, the question might be, what's this person's cardiovascular risk? Later on down the track, the question might be, should I increase the dose of this anti-lipid drug? So you can have the same test, same patient, same problem, but different parts of the medical pathway will mean you're actually asking a different question. So the patients I'm just going to talk about briefly here as examples are a 7-year-old, a 30-year-old and a 67-year-old, just to mix things up a bit. And it turns out this 7-year-old, the question we're actually asking is, does this patient have familial hypercholesterolemia? Now, familial hypercholesterolemia is an inherited, if you like, autosomal dominant, so it's very strongly inherited through families, disorder of lipid metabolism that gives people a very high cholesterol level right from a very young age. And the importance of this is because their cholesterol levels get so high, even high enough to accumulate cholesterol in their tendons and all sorts of funny places, it's very important to identify the people early. It's still a bit debatable about what you do until they're in their early teens, but you should at least identify them. And I'll talk a bit more later on about the role of cholesterol in sort of different types of screening programs. And as you probably know, with screening programs, it's always not always cut and dry that yes, it's worth doing the screening. So I'll talk about screening in familial hypercholesterolemia later on. The 30-year-old, I'll talk about their problem is metabolic syndrome. So I don't know if you're aware of metabolic syndrome, it used to be called Syndrome X. It's largely a combination of features that give people a higher cardiovascular risk and a higher risk of progressing to diabetes. So its main indicator is waist circumference hypertension. So basically obesity, hypertension, and then in lipid-wise they tend to have a mild hypertriglyceridemia. I won't go into the whole thing, but metabolic syndrome is a particular problem in our society, and even chemical pathologists that talk about metabolic syndrome don't necessarily lose weight. And then the question for the 67-year-old is they've had a heart attack. Should we start statins, which is an anti-cholesterol drug, if you want to think of it that way. So they're examples of the types of questions you might be facing in a general practice. Metabolic syndrome is extremely common. Familial hypercholesterolemia is probably underestimated, but it's relatively rare, but it's very important to pick up early. And the statins after heart attack are also a very important part of primary care. So I'll go more into this question of what healing process might be in play at particular different times. And the way I've split it up is that, excuse me, sometimes you're wanting to reach a diagnosis, so sometimes and this applies across a whole range of tests, not just for lipids, and so you can think of this when we're looking at the other types of testing we're talking about later today. You might be wanting to make a diagnosis about a particular condition, and so for example in familial hypercholesterolemia that's what you're largely doing. The other thing you can be doing is assessing the severity of a particular condition, or you might be looking for disease effects in a particular condition. So if they're, for example, diabetic, how much is their hyperlipidemia contributing to their cardiovascular risk? Sometimes it's trying to work out alternative diagnoses, not so much in lipids, but in some of the other testings. The question isn't, is this disease X? The question is it looks like disease X, but is there a possibility of it being Y or Z? And so you do some tests sometimes focused on differential diagnosis rather than direct diagnosis. Sometimes you're just monitoring patients, so you might have a patient that's on statins of cholesterol and you might be seeing whether you need to increase the dose, or you may be just in some conditions monitoring disease activity. For example, if you're doing a C-reactive protein in arthritic diseases, you might be monitoring disease activity of the arthritis. Sometimes you're looking for complications, so for example in some situations anemia might be a complication of the particular condition. You're not really diagnosing it as part of the person's primary problem, but you're looking at whether their problem is impacting on other parts of their health, so it can be looking for complications. Sometimes you're looking for associated conditions, so for example if you're thinking of, if you've got someone with ulcerative colitis, you might be doing liver function tests because ulcerative colitis is an autoimmune type disease, and then primary sclerosing cholangitis is a related autoimmune disease that affects the liver in 7 or 10% of the ulcerative colitis patients. So when you're doing liver function tests in ulcerative colitis patients, really it's nothing to do with the ulcerative colitis in some ways. You're often looking for other diseases that might be associated because they may share a mechanism with the disease of interest. And then the other thing you might be looking at is treatment questions. So when should I initiate treatment? How strongly should I go in for treatment? For example, with the anti-cholesterol statin treatment, some people always start low and just build up their dose. Other people find if the cholesterol is really high, then they'll go to a higher dose earlier. There's a few different protocols for how you might approach that. And just on that question of protocols, I think one of the important things for people moving into particularly a new treatment or diagnostic setting is to get an idea of the lie of the land and how things are done in those places. Sometimes it might not be what you're used to, and then you've got to face the question of, well, if I got this, is it something I should try and change, or is it just different views of, there's different ways of doing things and there's no clear winner, so we'll go with the local practice unless there's a very good reason to change. And over my career, I've changed pathology practices a few times, and usually one of the first things I do is sit down and just go through their past results and have a look at what type of comments they put on, and so you can work out from there where people, how people think in practice, because they can tell you, oh, we do this. And when you go back and actually, if I'll give you permission to go back and go look through people's records, then you'll actually see what they do. They might say, oh yes, for our diabetic patients we do this. When you go back and look at all the diabetic patients, well, they don't really do that. They also do this as well. And so I find also even in professional pathology practices, it's good to find out what's actually done as opposed to what you might expect the standard protocol to be. So now coming back to the 7-year-old, when looking at this, the question is familial hypercholesterolemia, and you'll find that there's, if you go into the literature, that there's guidelines for the diagnosis and management of familial hypercholesterolemia. That's a consensus document with the Heart Foundation and then supported by the Cardiac Society of Australia and New Zealand as well. You'll find during my talks I make quite a few references to guidelines and protocols and recommendations, because I think it's really important to get that consensus back up on what your practice is. Even if you decide, well, I'm not going to do that, at least you've heard what a group of experts think. And when I say you might not agree with it, often the American experts don't necessarily agree with the European experts, and they don't necessarily agree with the Australian experts. So even the experts might disagree, and you may be in a situation of having a look at a few different guidelines, if you like, cherry picking which parts or which guidelines you think most suitable for your particular setting. And sometimes the question about which guideline to follow will partly be related to what resources, or what sort of resources you have available in that particular setting that you're working in. So some of the things that are recommended for largely urban practices, you might think, well, that's going to be really hard to do in this particular rural area. It shouldn't mean you give a lower standard care in a rural area, but you might need to take a different pathway to achieve the same sort of outcomes if particular resources aren't available. And so I think it's very important to have a look around, and these days with Google or PubMed being the literature searching through the National Institutes of Health in the United States, there's lots of different ways of finding out what the guidelines are, or you can ask local physicians or some of your peers to see what sort of guidelines they've heard of or what they follow. And you'll often find too that some of the patient support groups are quite active in either supporting guidelines or promoting guidelines once they're available. Of course, they do also have a bit of a vested interest, so you need to see how much those sort of guidelines are based on expert opinion or on particular studies. But again, that's part of your professional job, is to get used to looking at the different options for how you practice and then working out what you'll be doing. Before I go more into the familial hypercholesterolemia, I'll just put it in the context of what it actually is. Now, Hyperlipidemias, and I'll talk about this later a bit further down the track. There's basically what are called primary hyperlipidemias, which tend to be the genetic hyperlipidemias or the inherited hyperlipidemias. So these are people whose lipid abnormality may be modified by the environment, but certainly they have an underlying genetic predisposition to have particular lipid problems. And then there are other conditions which are called the secondary hyperlipidemias, and these are more related to some environmental or disease process that's impacting on the person. So irrespective of their genetic makeup, if you're diabetic, you're going to have largely these sort of problems. If you have an underlying genetic makeup that interacts with that could be worse, but it's still largely driven by the diabetes rather than by the person's individual genetics, where some of these other conditions are driven by the individual genetics rather than what they're doing. They might be just living the same as the person next to them, but they've got these terrible lipids because their lipid metabolism has been disordered by some inherited malfunction, essentially. So, for example, in these ones, the familial hypercholesterolemia is a receptor problem, and I'll go more into detail in a minute. Another one is called defective ApoB100, and that's a target problem. So a lot of the times when you're looking, I didn't go into the full lipid metabolism because that can be a whole week-long conference on lipid metabolism if you want to go into that detail. But just in general, we think of just cholesterol floating around maybe as an LDL particle, and then you've got some HDL particles, but as you probably realise, it's very important. These particles all have different proteins attached to them or part of the particle as well. And one of the roles, there's a few different roles of these proteins in these particles. Sometimes it's to actually metabolize the lipids in the particle into something else. But quite a few of the times, the actual role of the protein is to be a target or a hook to take that particular lipid to a particular place. And so, for example, with the LDL, you can have an LDL receptor that is particularly designed to recognize the protein structure of an LDL particle and take it into the liver for processing, or process it another way. So the other type is a familial combined hyperlipidemia. This is where you've got a inherited overproduction of a particular, the ApoB100. These are all very specific genetic mutations, and they're relatively rare. Probably the more common sort of genetic hyperlipidemia you're likely to see in general practice or anywhere is what we just call polygenic diseases. So these are ones where they might have 200 different genes all contributing towards the condition. So there's a relatively strong genetic component to it, but there's not one single thing that's causing the problem. And so that's why you can often feel it runs in the family but not actually tie down an exact inheritance pattern because it's polygenic. A bit like that, the agricultural people thought, oh, this is good, we'll work out which cows give the best milk and we'll just get lots of cows like that. But when they went into it and tried to work out what genes control milk quality in cows, they stopped after about 200 genes because it's all a whole lot of little things adding up to produce a really good milk. And similarly, in people, it's a lot of the times, a lot of little things add up to produce the sort of person we are. It's relatively uncommon to have one problem, one genetic thing giving you a problem. However, familial hypercholesterolemia is one of those things where you just have one problem. And so autosomal dominant means that just getting one bad gene is enough to give you the problem. There are things like cystic fibrosis, which is autosomal recessive, where you have to have two bad copies before you get cystic fibrosis. But with the familial hypercholesterolemia, it has such an effect that you only need to get one copy of the gene from one of your parents to actually have the problem. It's called autosomal because it's not related to sex, so things like Duchenne muscular dystrophy, the gene in question sits on the X chromosome, and so it tends to be a male condition with female carriers because it's riding along with the sex chromosomes. But when we say autosomal, we mean it's on one of the other chromosomes, and so it doesn't really relate to male, female carriers and those sorts of things. So the problem with familial hypercholesterolemia is the LDL receptor isn't taking up the LDL properly. This is a diagram of the LDL receptor. Probably used to sort of seeing those things. So this is a cell membrane. It's got a tail that's holding it there. And then you've got this squiggly bit which is actually designed to recognize an LDL particle, capture it, and then it gets taken into the cell and processed. So in familial hypercholesterolemia, this isn't working. There's a whole lot of reasons why this might not work. For example, in the French-Canadian population, there tends to be a large deletion in the gene, and it just happens to be what's called a founder effect. So one person with this problem came to Canada, and then all their relatives have that same thing. So sometimes you find populations that you're dealing with have particular enriched genetic conditions, if you like, that you have to be aware of if you're operating in that circumstance. So for example, if you're operating in South Africa, you need to be aware of a lot of the porphyrias, which are skin disorders from handling your breakdown of hemoglobin and other things incorrectly. At one stage, someone with that problem went to South Africa and that caused a problem. If you have a look at hemochromatosis, there's probably some Norwegian person came into different parts of Europe, and then everyone from there on has the hemochromatosis, and so it's largely a white Caucasian disease, and it's fairly rare in Asian populations just because of the way these very strongly acting genes can travel through particular population groups. And this is an example of a family, and so this person here may be the 7-year-old boy, for example, that you're looking at to assess whether they've got familial hypercholesterolemia. Until you do his cholesterol, you might only know that he had a mother that had an infarct and died from infarct at age 31, has another aunt that's got high cholesterol problems. The father, so the ladies are the round circles, the men are the square circles, the squares. The guy here has a normal cholesterol, but you can see the mother's defective gene could have passed to either of these children or both of these children or none of these children. But what you have to do is, once you have a family history like that, then you can look at the rest of the family, usually first degree relatives, to see if there's someone else that needs to be managed. Sometimes at 7 years of age, they might not actively manage him straight away. They may wait till he's a bit older, depending on their protocols, and start managing his lipids. One of the problems in managing lipids in children is it's hard to know if you're doing any damage by constricting their lipid metabolism, because you saw from that earlier diagram all the things that lipids are supposed to be doing in someone, and particularly in a developing body, you're not quite sure whether you might be interfering with that. Probably people are being a bit overcautious in holding back, but and people are tending to treat younger, but it's always been a concern as to when you start lipid treatment in children. I was going to talk about the question of screening. So this is an example of what you might call directed screening or cascade screening, or in other words, finding some index case or some person that's got a problem and then tracking it through families to find other people with the problem. And for some conditions, and it's been suggested this is the best way to go, because you end up only really testing people that are highly likely to have the condition, and so you get a good value for the money you're spending on the testing, because you'll pick up quite a number of cases. However, on the flip side is it is a very serious condition, and so there have been to and froing and debates about whether we should actually be in some way screening our whole population for familial hypercholesterolemia, maybe early teens, getting someone to go out to all the schools and do cholesterol pricks, for example, is one way you might do it. And usually the health economics people get involved in this, and they work out the economics of how much you're going to spend, how many quality years of life you'll give the people you find, as in terms of how much benefit they get. But also they take into account what's the downside of screening. So you'll have people potentially that may have some either complications of screening during actual testing, or they may just be worried for a couple of weeks while they're waiting for their result to come back, and so it's not always a straightforward decision. So this is just an example of where the current recommendation is not to screen everybody, but to make sure you thoroughly screen or look at families once you know someone has a familial hypercholesterolemia, and also to think about it. So someone might just say, oh gee, that's unlucky for her, she had a cholesterol that was high and had this problem. I mean, it could turn out to be a polygenetic hypercholesterolemia where everyone's got a relatively high cholesterol and she's got a particularly high one, and there's no particular, intervention apart from what you would have done when you found their high cholesterols. But on the other hand, you can think, well, is this part of a familial hypercholesterolemia family? And what should I do? So that brings us back to these guidelines for diagnosis and management. You won't need to read all these, but basically it's giving a list of clinical and laboratory ways of working out whether the person is likely to have an LDL receptor defect and so be a familial hypercholesterolemia, or whether they're just someone with a high cholesterol for other reasons. And so when you're looking at your cholesterol results that are coming back and they seem to have a very high, here they say if once your LDL cholesterol starts getting above 6.5, they talk in terms of LDL cholesterols, then you're starting to think about it. Even at 5, an LDL cholesterol, you might think about it, but you need to have some other features. So you'll find quite a few times when you're working out, does a person have a particular condition, they'll have this sort of scoring system. So you get 3 points for an LDL of 5, you get 5 points for an LDL of 6.5, you get 8 points for an LDL of 8.5, and then you factor in the other clinical features and work out on the basis of the score whether they're likely to or not. The reason they're doing all this is actually they say you could look at DNA studies of the LDL receptor, but that actually is quite hard because there's a whole range of mutations that can do it. And certainly, probably in the not too distant future, DNA testing for a lot of hyperlipidemias will become more common. But at the moment, they're still better to find out from the clinical and general laboratory aspects whether the person has it or not, rather than diving into what is either very expensive or very difficult and not always completely helpful DNA testing. So although DNA testing is coming onto the scene more and more, it doesn't always give us the answers we need at this point in time. So that was the talking about the child with query familial hypercholesterolemia. Now, next thing is metabolic syndrome, and I've done whole talks about metabolic syndrome, so I'll just do a few mentions of it. But there's a couple of different things we're doing when we're looking at someone where we're querying metabolic syndrome. Partly it's diagnosis, because usually a mild hypertriglyceridemia is part of the diagnostic criteria for metabolic syndrome. So it's largely waist circumference as a marker of central obesity, hypertension, and then lipids, in particular triglyceride elevations, as a reflection of insulin resistance, is what you're looking at to make the diagnosis. Also, it can be a way of assessing severity, so you might be more worried about someone who had a triglyceride of 2.4 as opposed to a triglyceride of 1.9, although you probably should be treating everyone just as aggressively in terms of lifestyle interventions, which is the main treatment for metabolic syndrome. It's a bit like with metabolic syndrome, there's some good news and bad news. The good news, it's lifestyle determined. The bad news is lifestyle determined, because it's really hard to change lifestyle. And so the other one I wanted to talk about is the 67-year-old, and the question is, should we start statins after a heart attack? So you might be thinking, well, it's sort of a diagnosis. Is it a diagnosis, or is assessing disease severity? And again, you might turn to guidelines and saying, well, what is the role of measuring? Because what you're thinking of is statins are an anti-cholesterol, so how do I work out if this person should have their cholesterol lowered? And you could have a look at some guidelines. I'll zoom into these in a minute. But there's a whole lot of guidelines called NICE guidelines, which are basically a UK government produced program of different guidelines of management, largely for the NHS, but a lot of other places have accepted them, and even if you don't accept them, it's worthwhile having a look at them often to see what their approach is. When I say don't accept them directly, is so for example, if you're thinking, oh, should I screen for screen for people with adrenal problems in babies. So one of the things you can do is have a look to see whether the child has an inborn error in their adrenals, so that they're at risk of very severe disease at neonatal period. Recently in Australia, where there was a working group, I was one of the members on it, that had a look at this question for Australian population, and the recommendation was yes, you should screen for it. About half the American states screen for it, half of them don't screen for it, and when the UK, I believe, did their NICE review of it, they decided not to screen for it. But it depends also on different setups. In United Kingdom, you've got everyone pretty close to a big hospital, even if they think they're far away, they're really pretty close in terms of Australian terms. And so how they weigh up the pros and cons doesn't necessarily match up with what applies in Australia, but it's still worth looking at what their guidelines are. And in this case, their recommendation is that in some ways it doesn't matter what their cholesterol is, because they've already proven that they've got high cardiovascular risk by actually having a heart attack. So once you know they've had a heart attack, knowing what their cholesterol is doesn't necessarily help you stratify them any differently. They're a patient that's got a heart attack, probably due to atherosclerosis, so even if the cholesterol isn't high in terms of what the population might feel is high, maybe it's too high for them because they have actually had the clinical problem at the end of the path of developing cardiovascular disease. So their recommendation is actually just to start, everyone who's had a heart attack should start statin therapy. So in fact, if you're measuring your cholesterol, if you think, should I measure the cholesterol, the answer is, well, not to decide whether they're having statin therapy or not, because best practice is that they've proven they've got heart problems, you try and get their cholesterol lower. It partly relates to, in the past you might have heard about studies where they had tried to match cholesterol levels versus cardiovascular disease in UK populations, Australian populations, United States populations, and they found that the effect of lowering your cholesterol sort of petered out a bit once you got below about 5.5. There didn't seem to be a lot of advantage. But then when they look at Asian populations who, largely because of their diet, can have much lower cholesterols, they did find in populations where your cholesterol actually keeps going down and down and down, the lower the cholesterol, the lower your cardiovascular risk. And the problem with having a look at it in sort of the white Caucasian sort of population of that particular diet was you just didn't have enough people with low cholesterol to actually see how good it was. And so sometimes, so the advice too, that's one of the things that supports statin therapy being used, even if you've got a cholesterol that doesn't seem too bad, probably a bit less is better for you. The other thing I mentioned is that sometimes it depends on your local practice as to whether you would do cholesterol before you do statin therapy. I mean, people are just so curious. You think, oh, how can I start this cholesterol treatment without actually knowing what the cholesterol is? And the answer is, well, you're just going to treat them and it'll be good for them. But a lot of times it's very hard to resist that temptation to actually look at the cholesterol before you start, and that's a reasonable thing to do. Because at least you could say, well, it gives me an idea if their cholesterol doesn't change. Is it something about, are they not compliant to the drugs? What should I do something else? But really, and the other thing is sometimes you'll find in local practices that if someone's got a fairly high cholesterol, I'll start with a high dose of statins to start with. Other people say, well, I don't mind whether they've got high or low cholesterol, just see how they go on statins, and they'll take their usual sort of, some people call it start low, go slow. They sort of start on a low dose and sort of slowly raise it up rather than trying to guess where they should jump in with a higher dose. So it depends a lot. When you're looking at your lipid results, you really have to be aware of the practice setting that you're in and what the protocols and approaches are of the different practice settings. So basically the question of what do these lipids mean is very dependent on context, the patient's problem, and where you are in the diagnostic process. That's what I cover as the main part of the talk, and I'll just open things up for questions for now. So if you have any questions, otherwise if you don't have any particular questions but are interested in lipids and cardiovascular disease assessment, I can talk a little bit about that as well. So before we go on, does anyone have questions?
Yeah, I've got a question. Just with you're putting someone on a lipid-lowering agent, and how, like, at some point do you stop that? You know, their cholesterols are down to 2 or 3, or like.
Now, usually with the statins, it sort of takes it down and reaches a new plateau, basically. So it doesn't keep pulling it down.
Yeah. So, I mean, I think there was some discussion around probably 18 months ago or so where they were saying, well, you know, there's a bit of stuff around statins, and are they really safe? And people were challenging their doctors about, well, should I really be still taking this? My cholesterol is now 3. So.
Yeah, I suppose there's a couple of answers to that. One is, and one of the things with statins is some people do get muscle aches and pains from statins, and it's probably fairly common. And there are, as part of those nice guidelines, there were further down guidelines about when you might measure creatine kinase as a marker for muscle damage in statin therapy. Other people say it doesn't really matter what the CK is. If it's bothering them too much, then you can talk about whether to come off it or not. I think the problem is there's a lot of randomised controlled studies about putting people onto statins, but I think one of the problems then is, you know, there's not that many studies probably on taking people off statins.
But I guess if the risk factor's still there, so regardless of the fact that their cholesterol is 3, if they've still got the other underlying risk factors, then they need to stay on.
Yes, well, I won't be talking about sort of treatment, but yeah, certainly with things like statins, you could make a case that, you know, even down to 2.3, they show that's an advantage of having probably a cholesterol of 2.3 versus 3.3, for example. So maybe sitting on 3 is just the thing you want, not that it's too much.
Is there a role for fish oil? As you know, a trainer thought of before the statin, let's start the fish oil. And I've seen 2 patients recently who over a period of 2 months and brought their cholesterols down.
I don't have any direct experience. I haven't looked at the literature on fish oil, but I suppose make a few comments. It's not the recommended approach. I suppose, you know, you've got to think, well, what am I going to follow guidelines? With fish oil, I know there's been a bit of debate about which, you know, it's not clear which fish oil you should be using. Should you be using deep sea Norwegian fish oil because their lead levels are lower than other people's fish oils, and you know, different questions like that come up. I guess there's, well, the other thing, I don't know if what part two I didn't actually talk about is that the decision whether to initiate statin therapy should be made after informed discussion between the healthcare professional and individual about the risks and benefits of statin treatment, taking into account additional features such as comorbidity and life expectancy. So, for example, a very old person might decide they're not going to fiddle around with statins, they just want to leave it alone. That also would cover things like fish oil. You know, if a person feels that a bit funny about being on statins and they think the neighbour had a really good result from fish oil, then you can probably have a discussion with the person and talk about using fish oil, certainly. And the other thing is sometimes, with putting on my more clinical hat, is if you're giving people something like fish oil, it may also motivate them to do other sort of lifestyle interventions as well, and certainly give them that feeling that they've got a bit of control about something. You might even, I don't know, whether the fish oil tablets look better than statin tablets. They look like they're going to do more for you. Because I couldn't find even the colour of tablets determines how good they are for different things. Pardon? Yeah. So yeah, that's one of the question I think too. If you're having a look at trials and things, you have to see how much was being taken, whether that's something that someone's going to consider.
And as you said, the brand of it and stuff as
Hmm.
The other question I have is around the cholesterol ratio, and is it there's a move towards percentages and non-fasting.
Yeah,
testing?
I'll just go on to that. That was really, I said I could talk about lipids and cardiovascular disease management. That's where that cholesterol ratio comes in. So I'll mention that. So I said a lot of the use of lipids is for actually risk assessment. It can be for treatment selection. Sometimes you just have to do a test, so they'll give you some money to do something else. If it's expensive to have people on statins, it used to be that, or sometimes could still be that you have to have a demonstrated cholesterol above a particular level to get the government to subsidise it. And then sometimes you also might have treatment targets. But going to prevention, which is what we're really trying to do, is to prevent cardiovascular risk by identifying patients at what's called got the highest absolute risk. So that's where you start using the total cholesterol to HDL ratio. And you may see charts like this, which are a risk chart where you have a look at a number of features. So part of it is whether they've got diabetes, part of it is whether they're a smoker, part of it is what their blood pressure is, age, sex, and then down here I've mentioned that total cholesterol to HDL ratio. And so in terms of the recommended guidelines for assessing someone's cardiovascular risk, that's right, that ratio is at the moment the recommended way to approach it. You do have some riders on that. There are some levels of absolute cholesterol where they say don't worry about the ratio if your cholesterol is greater than 7.5, something like that. Then you're already at a high risk and we won't necessarily do that. In terms of fasting, non-fasting, the recommendation is, if possible, to have a fasting lipid study, but they say if that's not feasible for whatever reason, whether it's patient convenience or whether it's diabetes or something else that they're not keen on having fasting levels, then you can do it on a non-fasting level. The main advantage of fasting levels in lipids is in assessing the triglycerides, because the cholesterol doesn't change too much fasting, non-fasting, but you can get giant changes in triglycerides between fasting and non-fasting states. So if you're assessing someone for metabolic syndrome, it's particularly important you should do a fasting triglycerides as part of the assessment. But for cardiovascular risk assessment, they recommend fasting, but will accept non-fasting if necessary. That was part of the debate too when they started doing cholesterol testing in the malls in the 80s as to whether you should is it good or bad to do it fasting, non-fasting. And the idea was it's better to have a non-fasting cholesterol than someone not know what their cholesterol is at all. Probably the answer today is it's probably better for some health professional, whether it's a nurse practitioner or a general practitioner, to actually fully assess the patient and all these features to advise them, not just have a random have a cholesterol done in the shopping centre, even though it's a good sort of promotion in terms of PR.
I was thinking more along the lines of the people that might not necessarily come back, and you can do it right there and then. And what you're saying is the triglyceride is really important, non-fasting.
Yes, but often you're not using triglycerides so much, and although it's an independent risk factor for cardiovascular disease, usually there's only a more limited number of times you're actually interested in the triglyceride. There's more or less cholesterol in the total cholesterol HDL ratio. But there are times when fasting is very important if you're looking at the triglycerides. Any other questions on